Dynamics is the topic of our discussion today. What is the definition of urodynamics? It is a functional assessment of lower urinary tract, usually performed to provide objective pathophysiological explanation of the symptoms and dysfunction. The goal of urodynamics is to reproduce patient's symptom. Urodynamics are indicated when the diagnosis is uncertain after initial history, when the symptoms do not correlate with objective physical findings, failure to improve with conservative management, and when we plan surgical interventions. Urodynamics help to identify bladder outlet obstruction, stress urinary incontinence, detrusor instability, hypoactive bladder, and intrinsic sphincter deficiency. Is urodynamic required in every incontinent patient? The answer is no. Urodynamic is not required before commencing non-invasive treatment for storage symptoms. It is not recommended before surgery in women who report only pure stress urinary incontinence symptoms or stress predominant mixed urinary incontinence based on history and examination. The components of urodynamic testing include uroflowmetry, cystometry, pressure flow study, urethral pressure profile, electromyography. Screening for voiding dysfunction is done by uroflowmetry or post-void residual volume. What is uroflowmetry? It is a test that measures the volume of urine released per unit time, the speed at which it is released, and how long the release takes to diagnose or exclude the voiding difficulties. Units are ml per second. How is uroflowmetry performed? In this procedure, patient is asked to drink water until feel ready to pass urine, then empty bladder on uroflowmeter. A graph of flow rate ml per second against the time second is recorded. Normal urine flow curve is like this. As you can see here, the uroflow pattern is bell-shaped. The voided urine volume is more than 200 ml. The average flow rate is more than 15 ml per second. The maximum flow rate is 20 to 30 ml per second. The flow time from initiation to completion of urination is 15 to 30 seconds. Here we have abnormal plateau-shaped graph and decreased Qmax. Here the Qmax is 7 ml per second, which normally is 20 to 30 ml per second. Here we have superflow or tower pattern due to poor urethral resistance, and that is in fact an abnormal pattern. Now here on the top right side, you can see the uroflow shape. Here we have several peaks in Qmax ml per second. It is usually caused by repetitive Valsalva maneuvers, straining leading to fluctuating and intermittent strain. In the next graph, you can see the reduced Qmax. So here we have a rapid upstroke but with reduced Qmax giving a plateau shape. The possible causes include a urethral stricture, external urethral compression, or bladder outflow obstruction, for example with prolapse following continence surgery, failure of bladder neck relaxation, and acontractile detrusor. In the last graph, very high Qmax is shown. Here we have a rapid upstroke and downstroke, and that indicate possible detrusor overactivity and high-speed squirting to overcome an obstruction. In order to check the voiding function or dysfunction, we also check the post-void residual volume. In fact, the uroflowmetry is followed by a bladder ultrasound to measure the post-void residual volume. What is post-void residual volume? It is the volume of urine remaining in the bladder after completion of voiding. It is measured using a sonographic bladder scanner or transurethral catheterization. The normal post-void residual volume is usually less than 100 to 150 ml. Normal voiding is about 75 to 80% of total bladder volume. Increased post-void residual volume occurs in urinary retention, recurrent UTI, urethral obstruction, for example, pelvic mass, anterior vaginal wall prolapse, TVT or TOT, that is too tight, neurogenic dysfunction, poor detrusor contractility, for example, in case of the diabetes mellitus, and in cases of the false positive with a bladder scanner, like in cases of the large fibroid and pelvic masses. Decreased post-void residual volume occurs in stress urinary incontinence. The bladder function tests include cystometry and the pressure flow studies. Cystometry can be simple cystometry performed by a gynecologist, or it can be multi-channel cystometry performed by urogynecologist. Cystometry, which is the simple cystometry, was done previously by filling the bladder with 60 cc syringe through the catheter. The aim was looking for first sensation to void, desire to void, and the bladder capacity. The first sensation to void comes at 100 to 200 ml. At about 150 to 350 ml, there is normal desire to void. The maximum cystometric bladder capacity is about 300 to 600 ml. The multi-channel cystometry is performed by urogynecologists and it produces cystometrogram. Multi-channel cystometry procedure is explained here. First catheter is placed into bladder which measures the intravesical pressure indicated by PVES, pressure of bladder, vesical pressure. Second catheter is placed into either vagina or rectum which measures the intra-abdominal pressure, P-abdomen. The detrusor pressure is calculated by subtracting the abdominal pressure from the vesical pressure. P detrusor is equal to P vesical minus P abdomen. The intravesical pressure or P vesical is the pressure in the liquid present within the bladder. It is a combination of pressure generated by detrusor muscle of the bladder and pressure from abdominal cavity. The formula is P vesical is equal to P abdomen plus P detrusor. The mnemonic to remember is BAD, bad. B is for bladder pressure or vesical pressure, A is for abdominal pressure, and D is for detrusor pressure. The abdominal pressure or PABD is the net effect of forces exerted on the bladder by the surrounding organs of abdominal cavity. This pressure is measured in the rectum or vagina. It increases with Valsalva. The detrusor pressure or P detrusor is the net force exerted by detrusor muscles on the liquid. Detrusor pressure is equal to intravesical pressure minus intra-abdominal pressure. P detrusor is equal to P vesical minus P abdomen. Unlike the abdominal pressure, the detrusor pressure is not affected by Valsalva. Here we have normal values. The normal abdominal and vesical pressures in supine position is 0 to 18 centimeter of water. In sitting position, it is 15 to 40 centimeter of water. In standing position, it is 20 to 50 centimeter of the water. The detrusor pressure, which is equal to vesical minus abdominal pressure, is between -5 to +5 centimeter of water. The bladder compliance is obtained by dividing the change in the volume by the change in detrusor pressure during the same time period. Here we have idealized normal adult cystometrogram illustrating the filling and voiding phases. The compliance, which is the ratio of average volume to average pressure, is about 33.3 ml per centimeter of water. Here we have normal urodynamic tracing. On the top we have maximum flow rate, the highest flow rate at which the meter accuracy will be within maximum permitted errors. Next electromyograph is shown, which I will discuss with you later. The electromyograph here shows the recruitment leading up to the contraction, thus maintaining continence and creating an adequate void pressure. Next trace is that of the detrusor pressure, then the vesical pressure, abdominal pressure, and the volume. In this graph, you can see reduced QU flow. At the time of void initiation, the EMG electromyography shows the recruitment, however, quickly subsides and a voided volume is obtained. The detrusor pressure rises to mid-80s mm of water, which is not considered elevated at the time of void. The vesical pressure is also rising, probably because there is problem of sphincter relaxation. No marked change is seen in the abdominal pressure, and the most likely diagnosis in such condition is type 1 detrusor sphincter dyssynergia. In type 1 DSD, there is intermittent sphincter contraction throughout the detrusor contraction. In this graph, here we have Q uroflow. At the time of void initiation, the electromyography EMG shows recruitment that is intermittent throughout the void, resulting in flow with a peak of 12 ml per second. The detrusor, vesical, and abdominal pressures being shown here indicate that probably there is continuous sphincter contraction that persists throughout the bladder contraction. And here you can see almost no change in the volume. So that shows the type 2 detrusor sphincter dyssynergia. Now look at this graph. Here the Q uroflow is almost a straight line. At the time of the void initiation, the EMG shows a crescendo, decrescendo firing pattern throughout the void. There is elevation of detrusor pressure and with no appreciable voided volume. This happens in type 3 detrusor sphincter dyssynergia, in which there is sustained sphincter contraction that persists throughout the bladder contraction. In this graph, the bladder volume rises to approximately 820 ml with minimal change in P vesicle. Patient is asked to void a volume of 820 ml with no appreciable detrusor function or change in sphincter EMG. Here you can see that detrusor pressure is not changing and also not EMG pressure. This pattern of voiding function was taken from a patient with sacral level lesion. So the most probable diagnosis is elevated compliance with an acontractile bladder. Now, how to diagnose urodynamic stress incontinence? Stress incontinence is involuntary loss of urine that occurs when physical forces on bladder are increased during physical movement of the body. In contrast, the urodynamic stress incontinence is defined as involuntary leakage of urine during increased abdominal pressure in the absence of a detrusor contraction. It means when the stress incontinence is confirmed on urodynamics, it is called urodynamic stress incontinence. In this graph, you can see urodynamic stress incontinence. There is increased vesical and abdominal pressure, and there is leak associated with that. The detrusor muscle pressure is not increasing. In urodynamic stress incontinence, increased abdominal pressure along with vesical pressure results in observed urinary leakage that is independent of detrusor muscle activity. How to diagnose neurogenic bladder on urodynamics? Neurogenic bladder refers to urinary bladder problems due to disease or injury of central nervous system or peripheral nerves involved in the control of urination. Basically, in neurogenic bladder, there is usually reduced awareness of bladder fullness and a low capacity bladder due to reduction of inhibition of pontine maturation center by the cortical and subcortical structure damage. Here in urodynamic graph of urogenic bladder, there is urinary leakage along with normal abdominal and vesical pressures. There is also involuntary leakage of urine, but the sphincters are relaxed. Here also you can see the involuntary detrusor overactivity, probably due to reduction of inhibition of pontine maturation center by cortical and subcortical structure damage. Urodynamic detrusor overactivity is defined as urodynamic observation of involuntary detrusor contractions during the filling phase that may be spontaneous or provoked associated with urgency. Here we have normal compliance with normal to high volume of 700 ml, frequent uninhibited detrusor contractions throughout the filling period. This pattern is often encountered in Parkinson's and multiple sclerosis patients. So the most probable diagnosis is detrusor overactivity here. In urodynamic stress incontinence, there is a rise in abdominal and vesical pressure with a leak, which you can see here. There is no rise in the detrusor pressure. In detrusor overactivity, there is rise in detrusor pressure associated with leak, which you can see here. How to reach to diagnosis? When there is detrusor overactivity with incontinence, there is a rise in P detrusor and P vesical plus minus leak. In urodynamic stress incontinence, there is a rise in P abdomen and P vesicle with a leak. In detrusor overactivity with sensory urgency, there is a rise in P detrusor and P vesicle plus sensation of urgency. Here in this graph, throughout the filling phase, there is consistent rise of P vesicle and P detrusor despite low volumes of 200 ml which continue above 50 cm of water without an appreciable void attempt. No notable detrusor overactivity or DSD is identified, and this pattern is often encountered in spina bifida patients. Another component of urodynamic is pressure flow studies. These are used to evaluate the widening phase and are useful for the patients with incomplete bladder emptying. How pressure flow study is performed? Because a pressure flow study is performed after cystometric test, a small soft wide pressure catheter, that is manometer, will already have been inserted into patient's urethra. Another small pressure measuring catheter may already have been inserted into her rectum. In addition, she will have full bladder, which is filled with sterile water or saline solution as a part of cystometric test. The pressure flow test begins when the patient is asked to empty her bladder in a special toilet with the catheter in place. The manometer will measure how well the bladder muscles work by detecting the pressures associated with the flow of urine. The diagnosis of bladder outflow obstruction by pressure flow studies is done by high maximum detrusor pressure, high urethral pressure, and slow urine flow rate. In case of poor detrusor contractility or underactive detrusor muscle, we have low detrusor pressure, normal relaxed urethra, and slow urine flow rate. Next component of urodynamic is urethral function test, which help in detailed diagnosis of stress incontinence. There are two reasons of stress urinary incontinence, which include intrinsic sphincter deficiency and hypermobile urethra. On urethral function testing, when we have stress urinary incontinence plus decreased urethral pressure of less than 25 mm of mercury, that indicate the intrinsic sphincter deficiency. But if along with the stress incontinence, there is increased urethral pressure of more than 25 mm of mercury, that indicate the hypermobile urethra. What is urethral pressure profile? It is the urethral pressure of liquid that is required to force open a collapsed urethra to allow the flow of urine. In storage phase, the urethral pressure is collapsed to 0 cm of water. In voiding phase, the urethra opens to allow flow of urine. Electromyography is used to evaluate the coordinated relaxation of pelvic floor muscles during voiding. It is indicated in patients with dyssynergic or dysfunctional voiding. How to perform electromyography? During a urodynamic EMG test, a small electrode patches are placed near the urethra and the rectum. The physician then asks the patient to contract and release the muscle several times to test the area. The electrodes send signal to contract the muscle and record the response using a numerical value to show functionality. So basically, electromyography evaluates the pelvic muscle activity during bladder filling and emptying. During bladder filling, the guarding reflex is present. During voluntary voiding phase, both pelvic floor and urethral striated sphincter reflex is present. This table shows the normal urodynamic values. First sensation comes at 150 to 250 ml. Strong desire is there with a 400 to 600 ml. Detrusor pressure filling is at less than 15 centimeter of water, and detrusor pressure voiding is at less than 70 centimeter of water. Peak flow rate is at 20 to 40 ml per second. The flow time is about 15 to 20 seconds. The voided volume is 220 to 320 ml, and the residual volume is less than 50 ml. Thank you so much. That was all about urodynamics. Subscribe on Obstetrics and Gynaecology. Allah Hafiz.